Hi and welcome back to another video of Medic Notes. This video will be on Guillain-barre syndrome. It is also known as acute idiopathic demyelinating polyradiculoneuritis, and it is a rare disorder where it occurs in 1 to 2 cases out of 100,000 per year. And this disorder is when your body's immune system attacks your nerves, and there might be a few preceding events where I will talk about it later on. So this picture shows a normal nerve versus a nerve affected by the Guillain-barre syndrome. So you can see that there is demyelination of the nerve. There are a few preceding events which are found to be associated with Guillain-barre syndrome symptoms. So most of the events are preceded with an acute infection, such as Campylobacter jejuni infection, cytomegalovirus, zoster, HIV, or Epstein-Barr virus. Other events, such as surgery, immunization, Hodgkin lymphoma, SLE, and thrombolytic agents as well. In 40% of the cases, no cause is found where they don't know what caused the Guillain-Barre syndrome. The clinical features, so it is usually preceded by an acute illness, mainly motor polyneuropathy with symmetrical, progressive, and ascending weakness over the lower limbs. And it may come on rapidly and affect all 4 limbs simultaneously. So unlike the other polyneuropathies, in Guillain-Barre syndrome, the muscles that are affected are usually the proximal muscles, such as the trunk, respiratory, and cranial nerves, especially the 7th cranial nerve, which is the facial nerve. Pain is common, for example, at the back pain or limb pain, but sensory signs may be absent. Areflexia occurs early and is generalized. And bladder or bowel dysfunction is a rare presentation, and other features include autonomic dysfunction, such as tachycardia, changes in the blood pressure, sweating, and even cardiac arrhythmia. So for investigation, we can do a lumbar puncture for cerebrospinal fluid analysis. This is to look for cytoalbumin dissociation, which is a characteristic finding in Guillain-Barre syndrome. So it means that there is high protein levels, whereas the white cell count in the CSF is normal. We can also do nerve conduction studies where there will be slow conduction and showing a demyelinating pattern. For management, general management, monitor the vital capacity and give intubation and ventilation if needed. Monitor the ECG and BP to look out for tachycardia or arrhythmia. Fluctuations of the pulse and blood pressure may occur. ABG should be done periodically, and in paralyzed patients, we can give subcutaneous heparin. Chest physiotherapy, prevent contractions by doing passive movements, applying ankle splints or other hand or finger splint. Adequate hydration and nutrition via nasogastric tube, urinary catheter, and analgesia if needed. So the treatment is IV immunoglobulin, which is now considered as the first choice of therapy for most patients. And it should be offered to all patients who have severe disease until they are unable to walk or requiring respiratory support. Another treatment is plasma exchange or plasmapheresis. Overall, the prognosis is good. Around 85% of the cases make complete or near complete recovery. That's all for this video. Thank you.